Well, kia ora and welcome. Some of our work to be prepared for new variants of COVID-19 emerging. So New Zealand's pandemic response has been based on really strong public health advice and the ability to adapt to circumstances as they change. And since the beginning of 2020, we've seen the virus evolve, and each variant has had different characteristics, and we've had to adapt with that. So this trend will likely continue, and we'll need to adapt our response as we go. And that's why I asked Dr. Bloomfield and his team at the Ministry of Health to devise different scenarios of how the virus might evolve and how that would potentially impact our response. It's fair to say that even though our understanding of COVID-19 has deepened tremendously since 2020, it is still not possible to predict how it will evolve. There is a lot of uncertainty. And in that context, having a highly prescriptive plan can actually be a liability. Instead, we need to be prepared for different scenarios and to be able to adapt as we need to. And this is what's called pandemic preparedness and the approach that's favoured by the WHO. So by playing out these various scenarios, we sought to understand what capabilities we need to maintain to be able to respond to future variants. And we're now clear on those capabilities. I'll hand over to Dr. Bloomfield to explain the process that he and others at the Ministry went through to develop the framework for the variants.
Well, kia ora koutou katoa. Thank you very much, Minister. So, as the Minister has said, to inform preparedness across government, the Ministry of Health has worked with a range of agencies and technical advisory groups to develop 5 new variant scenarios, each with a differing degree of severity and transmissibility, or actually more vaccine escape or immune escape. And this has led to the development of a variants of concern strategic framework. So under the framework, we'll continue to rely on, as we have to date, and it's served us well, this multi-layered system of defence with strong public health measures to ensure that our systems, our service providers and our communities are resilient. Crucially, that the most vulnerable populations in our community are protected, and that any disruptions to health, to businesses, to social and educational outcomes are minimised. Now, prior to presenting the strategic framework to Cabinet, we did consult with a range of stakeholders, including public health experts, iwi, Pacifica, faith groups, community and business groups, and the disability sector. Of course, not everybody, but we have had the benefit of their feedback. We have made sure that te tiriti or waitangi considerations and equity, which has been a feature of our response right through, were foremost and really did inform this work as well. And this is important because, as we've seen in the delivery of the response to the pandemic, communities and providers serving those vulnerable communities in particular are crucial to an effective response. And so it's very important that they're involved in the development of these scenarios. Now, I should say, in a sense, these 5 scenarios, and I'm about to just describe them, are not rocket science. In fact, many countries are elaborating very similar scenarios, and certainly we looked at the work that was being done internationally. And in a way, they're quite predictable scenarios. But what they do is sort of range from what you might call a best-case scenario to a worst-case scenario. Now, of course, there's an old saying, plan for the worst and hope for the best. We're not doing any hoping here. We're planning for the best and we're planning for the worst and everything that's in between. And of course, what everyone's interested in is what's the most likely scenario. Well, perhaps we can come to that in the question time. Of course, that's hard to predict. But what we have seen over the last, since the Omicron variant came along, is rather than a whole new variant coming, we've seen variations of the Omicron variant, so these sub-variants. And I think the main reason for this is Omicron was a real step change in transmissibility. And so for each of these scenarios, we're assuming that the new variant has to be more transmissible than Omicron. So the transmissibility is a given. It will be more transmissible than the Omicron variants and its current subvariants in order to be able to displace Omicron from the community. So the two dimensions we're most interested in is what's the clinical severity of a new variant, and we saw with Omicron it was much less severe for individuals than the previous variants had been, in particular than Delta. And the second thing is what's the degree of sort of immune escape. So does prior infection or vaccination confer protection against this new variant? So therefore, the 5 scenarios we've ended up with is the first scenario is the one that I'm sure you will want to call, and one could call rightly, the worst case scenario. So a variant that's high clinical severity, so Delta or even worse, but also high immune escape, that is prior infection or vaccination with our current vaccines doesn't confer a lot of protection. And also there are questions about whether our current therapeutics may or may not be effective against that new that new variant. The second scenario is a variant with lower clinical severity but still high immune evasion. So in other words, it's not just more transmissible than Omicron, but it actually, our prior infection or vaccination doesn't really confer much immunity. So you see a lot of people getting infected again, so high impact in the community. And you'd imagine high case numbers with that. The third scenario is a variant that's got high clinical severity, so perhaps Delta or worse, but low immune evasion. In other words, actually, prior infection or vaccination does confer a high degree of immunity, but if you do become unwell with it, more likely to get very unwell and more likely to cause hospitalisation and death, particularly in our highly vulnerable populations. The fourth scenario, and these are all described in the summary that will be made available, is one that's low clinical severity, low immune evasion. In a way, you could just think about some of these subvariants of Omicron as a bit like this. They've got an advantage in terms of transmissibility, but at this point in time don't appear to be more severe and don't appear to be immune escaping in terms of prior infection. But of course, early days with those. And then finally, the fifth scenario is one where you might have multiple covariants circulating. We've seen this in the past where there have been mixed outbreaks of Alpha and Delta, and then of course early days of the Omicron outbreak we still had, or in other countries in particular, had both Delta, high rates of Delta and high rates of Omicron in the community. So those are the scenarios, and the key thing about this is, and I talked about planning for both the worst and the best and everything in between, is to make sure we've got the information and intelligence that is alerting us to whether and when these variants are in the community, that we've got the infrastructure, the workforce and the capability and capacity, for example, in testing and contact tracing, and that we've also got the coordination and decision-making mechanisms ready to stand up quickly if they are needed. Back to you, Minister.
And indeed, those decision-making mechanisms are well established through the pandemic, so ministers will continue to make decisions based on public health advice around how to respond to new variants, and those processes have served us well. And I think it's important to explain that being prepared for a new variant doesn't commit us to a particular course of action. It is much more about retaining capabilities in order to respond should we need to. So, and in each scenario, when a variant emerges, we will have to respond to it on a case-by-case basis based on those specific characteristics of that variant and the impacts of any decisions that we take. And it's important to note we are also in a vastly different situation from what we were in 2020 because of all the capability we've already built over the pandemic. So I'll talk at a high level about some of those capabilities that we've developed. We have a vaccination system that could be stood up to vaccinate the population if we need to vaccinate the whole population again at speed. We have the IT systems that underpin that and the purchase arrangements. We have a system for monitoring, distributing and stockpiling PPE. We have testing facilities, and Dr. Bloomfield could talk more about how we're, even though PCR currently isn't our primary test, we are making sure we're retaining our PCR capacity. We also have many other tests that we're using, including rapid antigen tests. The government has enabled much through $300 million ring-fenced for antiviral purchases, has enabled PharmAct to take a very proactive approach to that. We continue to have the systems and the IT infrastructure and a single national public health unit to enable contact tracing to occur. We will soon have a joined-up national health system to coordinate the response as of July 1. We have previously assigned $500 million for the development of further ICU beds. We've built skills through the pandemic, for example, in health promotion and community mobilisation. Those will be embedded in our new health system through Health New Zealand and the Māori Health Authority. And we have an integrated surveillance system based on cutting-edge science, including whole genome sequencing and wastewater testing. So Cabinet has taken a set of decisions to identify those capabilities and task agencies to assess their preparedness to deploy those measures and undertake ongoing activity to make sure that they can be activated rapidly in the future if they're needed. I know many of you will have questions about stricter measures, for example, lockdowns or border closures. These measures are absolutely a last resort. We know that if we have strong underlying public health measures, that our need for more stringent measures is reduced. And just look at what we've been able to achieve with reopening the border by using vaccination. And that's precisely what we mean here. By getting the fundamentals right, we reduce the need for stricter measures. However, COVID has taught us we need to remain prepared for a range of scenarios. I also want to mention that the objectives of our response is likely to be different. And I think if we're just going back to Dr. Bloomfield's comment about each variant, in order to emerge, must be more transmissible, that also means it's more likely to evade measures like lockdowns or like MIQ. And you can look around the world and see that that's made elimination very, very challenging. So it might be that if those measures are ever used, they're for different objectives, for example, to flatten the curve or to buy time. As always, all measures have to be proportionate and justified to be within our laws. So Dr. Bloomfield, could you comment a bit more on our operational work from here to embed these responses?
Thanks, Minister. So the work has been continuing anyway, as you can imagine, to continue to deal with the existing Omicron outbreak, which is significant, and also the emergence of some of these new subvariants, and we're seeing those create new, at least small waves of infection, even in the Northern Hemisphere. In the UK, we saw it first in South Africa, so the BA4 and 5. So we've got our existing work. But a good example of where we're making sure we've got capacity to respond to the current outbreak, but also planning for these future scenarios, is in how we will be contracting for PCR testing with our laboratories. And we're going through a process at the moment of making sure that we are funding our laboratories to have both the standing capacity to do the testing. At the moment it's several thousand tests a day, but also able to surge up quickly if needed to respond to a new variant. Remembering that, of course, one of the things we'll be interested in if there's a new variant is using our whole genome sequencing to find out the spread and where it is in the community, and that we can only do that if we've got PCR tests there. One of the things we're doing therefore is changing our existing contract, which had been which had been paying providers just on a test-by-test basis to make sure they're funded to have the standing capacity, but that surge capacity is also there over this next 6 months in particular. So that's an example. Our contact tracing system as well. Obviously, we're using that very differently from how we were earlier in the pandemic. However, we want to make sure we can surge that up quickly, that our providers and their workforce are still ready to go and trained, but that they're not sitting there waiting around, that they are doing other things in the meantime. Thanks, Minister.
All right. So our response to COVID has been world-leading, and we've kept people safe from some of the worst of the pandemic. But there have been many lessons learnt along the way, and this process is also about making sure that those lessons are embedded so that we can continue to protect New Zealand now and in the future. Very happy to take your questions.
Dr. Bloomfield, the traffic light system as it stands, when you look at that worst case scenario, will it stand up to that efficiently enough, or do more changes need to be made?
Minister, I'm happy to respond, but one for you as well.
You can go first.
Well, I guess the point I would make is, of course, as we talked about, actually our response has shifted as we've had different variants. So initially, we of course had the alert level framework. And remembering that actually the traffic light system, or the COVID protection framework, was developed while we were still in a Delta outbreak. It was intended to be our transition to a new way of dealing with a Delta outbreak. And in fact, it became the framework that we used to deal with the Omicron outbreak when it came along. We're continuing to look at the CPF and the existing elements of that CPF even as this Omicron outbreak continues. And there's no doubt that we can and should remain open to reviewing it and the settings that are in it, or looking to see if in fact we need a new framework in future if we have a new variant.
I think that just goes back to, in response to the question about the CPF, goes back to that point about how we'd be using tools for different objectives, and mostly for suppression, because elimination of a more transmissible variant wouldn't be possible. So in that situation, a hard lockdown might not be the type of approach that would be necessary, and something more like the CPF is probably what we have in mind.
They still, like a hard lockdown could still be used, and you referenced to buy time or to flatten the curve. So can you give a scenario in which that would occur?
So I said stringent measures might be needed in order to buy time or flatten the curve. So that might be measures at the border, for instance, But the point about movements and those sorts of movement restrictions is that if you're trying to flatten the curve, that is something you need to do for a long time, as opposed to the elimination approach, which was much more short and sharp. So then the question is, can something reasonably be sustained and achieve a public health goal in that period? And so that's what makes the feasibility of elimination with a more transmissible variant very different.
Is the public compliant, or is the public acceptability enough to be locked down, for example, for a month? In the case of a very severe variant where you need to vaccinate the population, for example, is that when the quid pro quo comes up about going to back to a very restrictive measure?
I think what we're trying to get across here is that a very restrictive measure, when elimination isn't possible, is not sustainable, and that's what puts us more in the frame of the CPF, of the COVID protection framework, traffic light framework type actions.
So you're saying that lockdowns just really wouldn't be used in many scenarios? Is that what you're saying?
Because they can't be used to eliminate a more transmissible variant. Yeah.
Does that mean that in hindsight, the very stringent lockdown approach applied to the Delta variant was perhaps not the right one, and we should have used an approach more akin to that?
Look, we came very close to eliminating Delta over the summer in combination with vaccination. Yeah, so I think that was a very finely balanced decision there.
Yeah, very close is very different to actually eliminate.
Well, by the time that became an issue, Omicron was also on the horizon, and then the next threat.
The opposition said that cost us billions of dollars. That the Delta lockdown cost the country billions of dollars and was unnecessary.
And Delta was an extremely clinically severe variant compared to what we currently have, and the population was largely unvaccinated at the time it broke out. So that lockdown was absolutely necessary.
Just to endorse that, and we were down to a handful of cases every day that were Delta at the time that Omicron came along, and so that's what we set out to achieve, because it was a clinically quite a severe variant, and you could see what was happening in other countries. And if you go back and look at their mortality waves, they had many of them peaked their highest mortality wave was during the Delta outbreak.
Do you think we're successfully suppressing COVID now?
Well, we are suppressing COVID to some level with the measures that we have in place. In terms of success, we have to, I guess, look across the range of factors we have to balance as a government. At the moment, we do not have excess mortality in any age group, which I think is a really important achievement now that cases have come down. As it turns out in our current situation, the pressure on our health system is largely flu, and the COVID hospitalisations are reducing. So yes, the measures we have in place, vaccination, promoting use of masks and so on, have no doubt reduced transmission, and we're keeping important public health parameters under control.
Are you able to give any more?
Do you see the COVID death sort of numbers changing significantly in the next few months? They've been between 10 and 15 a day on average for a couple of months now, and taking aside the 20% of deaths that are unrelated, that's still a minimum of 8 deaths a day on average, 3,000-ish a year. Do you see that changing without any change from government action?
I think the epidemiology of the answer is deaths depend on the number of cases, and those fluctuate a lot during the pandemic, and we're pleased that cases are currently tracking down over the last couple of weeks. We are about to make an important decision on the fourth dose, which we hope will get some extra protection for seniors whose coverage from the third dose might be reducing now.
Do you think that case trending down is that's reflective of what's actually happening in the community in terms of infections?
Yeah, my view is that it is, and over the last couple of months we've compared our reported testing or reported case numbers through the testing with our surveillance of our border workers and used them as a proxy. And I think, as I said last week, we've seen actually even just 3 or 4 weeks ago we were identifying about half of the cases in the community. It's now about 2/3, even as those case numbers come down. Our hospitalisation numbers are also steady; they're not going up, and what we have seen right through the Omicron outbreak is that tail of hospitalisations takes quite a long time to come down. I was in Dunedin 2 weeks ago and on their bespoke COVID ward, which is fantastic actually. Most of the people on that ward are people who had COVID. Incidentally, they were in for planned care or they came in for something non-COVID related. It does vary by district health board, but we're certainly seeing, as the Minister said, actually the main pressure on the health system at the moment is actually the burden from influenza. So a plug for people to get an influenza vaccine if they haven't yet.
Can you put some context around the reporting of deaths? And I know it's the measure that we report internationally, but are you able to give any better picture about the direct deaths as a result of COVID as opposed to people dying with COVID?
Yes, and we are now updating that regularly on our website. One of the things we did, usually the coding of deaths takes 2 to 3 months. Our coders are doing them within days now, so we're able to categorise those COVID deaths within 28 days into those 3 groups. Those where COVID was the cause, those where COVID was a contributor, but the person probably had a pre-existing condition that was the main cause of death, and those where it was completely incidental. As has been said, that latter group is about 20% of deaths, although it's a bigger proportion in younger people. So younger people are much more likely to have died from another cause, but incidentally to have had COVID. So we've actually got very good and rapid data on this, and actually the team looked at this just a couple of days ago. So there's a big lag, for example, in the reporting of deaths in the USA, and if we had a similar lag here, we would only be reporting about 850 deaths at this point in time. But we're not only reporting ours quickly, we're also able to categorise them quite quickly as well. So
in terms of, I suppose, the public information, and how important is it for people to understand that breakdown in terms of the actual number of directly COVID-related deaths as opposed to, the reporting model that people have got used to? And that there might not be so many deaths, not taking away anything from the people that have died, of course, but there might not be, that figure might sound or seem inflated sometimes.
The approach we've taken is to be transparent. We don't want to be arguing about why particular people died, so we just have to put the information out there and then contextualise it appropriately. We know other countries take a different approach. The US CDC, you have to have COVID as your cause of death on your death certificate to be classified in that way, whereas we're more consistent, I believe, with the United Kingdom and others that take a more inclusive approach.
The point can I just make one other point there is, even if it's only 80%, it's not a trivial number. I mean, this is still, the highest number of deaths obviously we've experienced. Remember, when we went into the Omicron outbreak with 56 deaths total, and then if you talk to colleagues overseas, their eyes pop when they hear that. And we'd much rather be inclusive in terms of counting our deaths, because that gives us an opportunity to look. And we're just doing some work on actually all the deaths that have occurred in Auckland in younger people, so under 60, which please say still includes me, in younger people, just to make sure there's nothing that we might be missing here, just to get that picture. And we'll get a much better picture if we're, in a sense, over-inclusive. And the really good thing is now we can give people a really clear picture of just the impact that COVID is having in terms of deaths in the community.
Regarding the fourth dose, the proposal is just to keep it to the high-risk groups. Why not open it up to the general population?
Well, what we do will be based on the Director General's advice. So.
And I've sought advice from our vaccination technical advisory group on this, and just got it in the last day or two, and finalising my advice up to ministers. The key point here, and this has been a feature of the advice from that group all the way through, is to make sure that they're clear about the benefits and risks equation. And we know there are risks from vaccination, including some very rare risks around myocarditis and pericarditis, particularly in younger people. And the group has been very consistent in its advice to make sure that any recommendations they have about who receives both the original vaccine in terms of different age groups as they've come along, and then the booster, and now with this second booster, to make sure that it's quite clear where the evidence is taking us around the benefits versus potential risks.
Is that second booster mandated in any way for any particular groups?
Well, I can say that my advice, and it's still forming, is already clear that no group should be mandated to have that second booster.
What's the immunity profile of the population, given that many people will be some months on from their third or booster shot, and obviously we've had exposure as well? So what's the actual picture and the level of immunity protection that would be in the wider community at the moment?
I think the best approximation of that is the vaccination rates, because that corresponds very strongly to immunity. So we know the most important doses, those first two doses, we have very high rates of boosters in the population over 65 and other target groups. In terms of the contribution of immunity from infection, yes, that gives you some protection, but I believe it's less than vaccination. So having had an outbreak gives some protection, but it is certainly not as much as having vaccination available.
How long do those benefits of the initial vaccination program actually last for?
Yeah, so what we've seen is that the benefits against severe disease appear to be long-lasting, but the benefits against infection may not last as long, and that's thought to be because of the different types of, because the antibody response wanes, or the virus evolves to escape the antibody response, but the other cells of the immune system, T cells, remain important for protecting against severe infection.
So that would be one of the mechanisms, obviously, if there's something that, our immunity rates need to be boosted up, then you would prioritise, or you would look again at that fourth booster rate for the general population if needed. I mean, is that...
And as we did with the emergence of Omicron, if the situation changed and there was evidence that vaccination was helpful, of course would consider it.
How much reliability is that heading into winter though? Sort of 72% of people have had the third dose? How does that cause concern?
As I mentioned, the first two doses is the most important for protection against severe disease. But of course, we want everyone who's eligible to have their third dose, and if they're eligible, have the fourth dose as well.
So we've got a report that shows there are significant blind spots in our surveillance for COVID, especially at the border. Does that concern you at all, and does it put us at risk of the new variants looking through?
So the importance about surveillance data is that it is different from testing. Surveillance is what we call information for action. So the point of surveillance is to get information about trends. And at the border, we have a very high rate of testing, over 90%. We know about 2% have, of those 90% crossing the border, have COVID. And then about a third of them currently go on to have PCR, and some of those have whole genome sequencing. We will not get a perfect system of everyone having whole genome sequencing in that setting. The point is to be able to identify trends there, and we also have the backup of community whole genome sequencing. We are, however, going to try and lift that rate of coverage with the whole genome sequencing, and there's you have a couple of IT projects underway, don't you, to make sure that we can trace the people who cross the border and match that to their sample.
So you're not concerned about blind spots at the border?
The point of the surveillance system is surveillance. It's not a clinical testing regime where we're covering everyone like we previously did.
With long COVID, how did different variants, if known, affect the likelihood of people getting long COVID, and what, if any, distinctions have you seen in types of long COVID?
Not sure if I've seen any papers on that one. We might have to get back to you.
I would make just 2 comments. Most of the people in New Zealand who have ongoing symptoms, and some who might fit within a category of long COVID, it will be secondary to Omicron infection. We had relatively low numbers of people who had been infected with earlier variants. Most of what's known about long COVID is from those earlier variants. So it's really an emerging field, and we've got research projects in the field, and we've got work on developing up services to make sure that anyone, when they touch the health system, if they have ongoing symptoms from COVID infection, regardless of whether those fit within a sort of technical definition of long COVID, that actually clinicians know what are the options to help them manage those symptoms.
Dr. Bloomfield, when the COVID vaccine technical advisory group weighs up the benefits and the risks, does it include the risk of long COVID from COVID infection in those calculations?
Not specifically, because what they do, what they focus on is looking at all the emergent evidence, and that is generally around the relatively short-term protection that a new dose of the vaccine in particular groups affords. And a lot of that is from countries like Israel and so on that have been sort of ahead of others in providing both that first and second booster dose. So they look specifically at that. Of course, they comment on the issue of long COVID, and it's one of the things that I take into account in providing my advice through to ministers. But they're most concerned with the balance of benefits and risks from the vaccination in the short term.
Right, because I'm thinking, if the vaccine provides protection, it makes it less likely someone gets COVID, makes it less likely they'll develop long COVID, could help younger people who don't fit into that high-risk category, who are still at risk of getting long COVID, even if their acute infection isn't that severe.
I think that's an important consideration, certainly, and I would say we just simply don't have enough evidence yet to be able to really consider that as a major decision criterion.
And on the surveillance sort of issue, less about variants, I guess, but you spoke during the Omicron outbreak about a prevalence survey and how that might be something the ministry would want to do after the wave sort of peaked. We're there now, and any updates on that?
Did you want to?
Indeed, it's part of our surveillance plan to do that prevalence survey, and it is in the stage of being planned how the field work will be.
Yes, in July we're expecting to go into the field with, so there's a sort of a prevalence survey, and there will also be a separate survey that will get blood samples to look at this issue that was raised earlier about the level of immunity across the population. And it is possible, I understand, to distinguish between the sort of antibody response that is secondary to vaccination and that which is secondary to actual infection.
And do you have an expectation on how regularly that information from that survey will be released? The ONS in the UK releases it quite regularly. Would we expect to see a similar sort of schedule or level of transparency?
Certainly about transparency, the point of the data is to inform the response, which obviously is bigger than just government. So,
Yep.
Yes.
I'd have to come back to you on whether the intention is for these to be sort of snapshots or whether their intention is to be more longitudinal. Remembering that one of the advantages we have over the UK is that testing is still free and being widely used here in New Zealand. We're seeing high levels of testing still, whereas in the UK, many of their estimates of cases have to be based on those weekly surveys because their testing rates in the general population have just dropped right down.
The Pacifico community is concerned that there's not the resources to roll out the fourth dose and that there's COVID fatigue, the health system's overstretched. What are you doing to overcome that to make sure there's good uptake?
Well, we continue to work with the providers who have done so much for strengthening the COVID-19 response. And that point about fatigue, I totally understand it because they have just done so well for the community. They will continue to be at the centre of our response. And I'll just ask Dr. Bloomfield to update on the arrangements for working with the community providers.
Yes, so the funding arrangements are still in place with those providers, and one thing that I'll be clear about in my advice to ministers is that the resources and the funding and the focus of the campaigns to roll out the fourth dose will focus on those populations who are at higher risk and who have the most to benefit, so our older populations and certainly our Māori and Pacifica populations and people with pre-existing conditions or with a disability. So we will work really closely with those providers to make sure they've got the funding and resources they need to support the rollout.
Have you consulted widely with those high-risk groups about that fourth dose? Because we were speaking to the disability sector and they said it's news to them that second boost is coming.
We haven't consulted widely. The advice I give is based on the advice I get from our technical advisory group, and that's the main input. And then, of course, I get a sounding from my other advisors inside the ministry and beyond, just to test my thinking before I put the advice to ministers.
Minister, are you asking that all positive border and community PCRs are referred to ESA?
We have been working really closely with the not all community PCRs would be referred to ESR. Only a sample of them would be. So this goes back to the point that surveillance is not about having a complete library of every variant that's out there. It is about being able to detect trends. So for both the community and for the border samples, we've asked experts to help us design a sampling frame. So how many samples do we have to have to get a good representative, accurate picture of what's going on? And that's the basis on which we ask for sample referrals to happen. Dr. Bloomfield's been working on this hard, so he may have a comment.
Well, just to say, for the border samples, we're quite keen to get, first of all, everyone who tests positive to go and have a PCR on a rapid antigen test to go and have a PCR. As the Minister mentioned, we've now got it in our IT systems an ability to link and follow up people who have registered a rapid antigen test to see if they've had a follow-up PCR, and if not, they can get a phone call or an email to follow that up and encourage them to do so. In terms of the community, the most important surveillance in the community are the people who are admitted to hospital, and so they're the ones we really focus our efforts on. They're also the ones who are more likely to have a PCR test, and those are the ones we certainly encourage the district health boards to send through, or the labs to send through to ESR. So even if they're not analysed, and they don't necessarily analyse all the samples they get, they can store them for up to 4 weeks. So if retrospectively they need to go back and take another look, they've got the samples there to do that.
So the most recent data shows that PCRs from hospital, from sick people at hospital, just 32% were referenced or referred for sequencing. Is that enough? Are you happy with that percentage?
I think that's a very reasonable proportion. What I'm also interested in, and this is something we're still working on, is making sure that there's geographical spread of those. So we know some DHBs have a much higher rate of sending samples through, and our aim is to have at least, if there are this many, at least 10 samples from each DHB every week or two going through.
Does do the scenarios that you're talking about specifically consider BA4 and BA5 subvariants? Because some recent studies suggest those variants are becoming more and more common overseas and may also have heightened immune evasion capabilities.
They're more a consideration in our current response rather than in the future scenarios, because they are here. We've got them in the community, we know, and so we're watching actively what impact they're having overseas, and also if there's any impact here, and this is where again, getting PCR tests and whole genome sequencing on our people hospitalised to see if there's any sense they are more likely to lead to more severe illness and hospitalisation. That's the most important thing there. But interestingly, they're emerging at a time when our 7-day average of cases is actually dropping. For the first time, really, it had levelled off for quite a while, and it's dropped in this last couple of weeks, which is good.
What more can you tell us about that study into Auckland deaths?
It's a piece of work that a colleague's got underway up there, and Sir David Skegg and his group have been interested in looking at this. So that piece of work I just found out about yesterday, it's being finalised, and we'll talk to it once we've got that finalised and it's been considered, and ministers have had advice on that. Minister, we'll be happy to speak to it, and it's actually been organised and led by Dr. Andrew Old, who's going to be the new head of the Public Health Agency, and I think it's going to be a really helpful piece of work, because it's really just trying to understand, especially in those deaths in younger people, the extent to which COVID played a role in those deaths, and what we can learn about that, and looking at things like vaccination status and so on.
Okay, shall we take 2 more questions?
Last week, Dr. Town mentioned that there would be new advice coming on isolation timeframes and in terms of what happens if you get a positive RAT test after your 7 days are up. Have you delivered that to ministers yet, Dr. Bloomfield?
I would say it's an active discussion with ministers at the moment.
Do you have a timeline for when that might be finalised and announced?
We have a set of announcements for next week that we'll probably make it in conjunction with that. Great. All right. Thank you very much, everyone.